this fairly open. So anything that I could help share, it's a smaller group with us, so we can really um, shape or adjust our discussion so that it matches whatever questions you may have or some other concerns or things that we can go over together. I am, and I think everybody here can see my screens here. So it's very nice to be here with everybody. And what I wanted to do is just go briefly over prostate cancer. I'm one of the urologic surgeons here at Penn. And so what we do is take care of a lot of, cancer patients, specifically with prostate cancer. So I do both the surgery and also research related to it. And one thing that we do a lot of is also genetic research, specifically for including, trying to figure out how we can better take care of the patients with prostate cancers, doing a lot of genetic research, especially understanding some of the disparities or differences that we see between race and socioeconomic differences. So I do have a lot of partnerships with the genetic research here and some of the other things that I'll be presenting too. The one thing that I did want to say is that if you have any questions, please feel free to ask me questions. We have a chat bot here or chat box that we can use. So feel free to either raise your hand, I can look at you, or use the chat functioning. And then any other questions that we can address, please let me know. For this part, I'll keep it on the shorter side because I want to really open it for questions. And I believe in our previous email, you said that you might have some case presentations as well. So if there, I'll go through these things very quickly, and then we can open it. Or if you want to go over some things more in detail, we can do that as well. So prostate cancer overall in most of the countries is really increasing, mostly because we are seeing increasing measurements in our ability to, how we measure and when we measure prostate cancer. And overall in Asia, but also in Africa, you are seeing increasing signs of cancer in general, but specifically with prostate cancer. We all know that prostate cancer does cause a significant amount of disability and mortality, especially when it's caught later in stage, where it causes some pretty debilitating pain and problems with that. But not just that, it is affecting the number of years lost in life. So prostate cancer and bladder cancer account for about 20 to 30% in the changes, or 20 to 30% decrease in the numbers of years lost because of cancer. So that is a very, very significant amount. In addition, overall, we will be seeing an increase in our lifetimes of 50 to 70% of prostate and bladder cancer diagnosis. So it's not just a big problem, it's a problem that will get more severe over time. So we have to be equipped for that. We have to learn more about it. So specifically in East Africa, prostate cancer is very high. Prostate cancer screening or PSA screening is relatively rare, and obviously, you all are very familiar with this, more familiar than what I see, but this is what I have seen in at least the literature and at least the studies that are there. There's a very high percentage of patients presenting with stage 4 or metastatic disease, and a large percentage of people even with severe cord compression that I was very interested to learn about. Overall, it seems that, especially in East Africa or in Africa in general, there's been a very dramatic increase in the number of prostate cancer deaths over the previous 20 years, which is probably related to, in general, health improving, people living longer, and therefore being more exposed to the potential problems with prostate cancer. This is a very good study that was done in cooperation with the Ghana prostate study, and they have a very good collected bank of both tissue material, but also screenings based out of Accra. And what they found that in general, even when we're comparing the PSAs, the general rate of prostate cancer that was found among men was higher, again, given adjusted according to the number or to the level of PSA. So basically what that study showed was that in general, we need better detection and also better screening practices in general. So can PSA screening work? In general, when we look at all the 3 different studies here, yes, it does save lives. And can lead to about a 40% decrease or improvement in prostate cancer death. So that is one of the important ways of figuring out how can we do that in a safe and reliable way. I'll skip this part. So going into how we do localized prostate cancer treatment, especially for prostatectomies, I just wanted to go over just the general practices. And these are things that I do spend a lot of time going through, just because the prostatectomy itself is very effective, but is quite difficult to do and manage, especially when you're first starting out. Especially for those who are trained in France, the French have a very long history of doing these surgeries very, very well. And in fact, a lot of our procedures and tools were named after some of the initial French surgeons. The first thing you start with after initial incision is the lymph node dissection. Obviously, you want to make sure that your borders with the iliac vessels and the obturator nerves, that's the main packet that you want to go to. And you're hoping to skeletonize these lymph node packets as much as possible with surgical clips or ties as much as possible. The second step that you get into is really cleaning up the prostate over here and getting into this endopelvic fascia. This is where I do see a lot of bleeding here, is right around the puboprostatic ligaments. You do have to be careful to not get into early bleeding before you gain control with suture ligation. So again, that's an example of what it looks like. And you can see here, this is what the prostate should look like once the endopelvic fascia is opened, revealing the prostate underneath it, but obviously taking care to avoid some of the dorsal venous complex that's right there, because that's where you will see a large amount of your bleeding. And especially what we notice, and what I noticed during a lot of my training sessions in East and West Africa, your prostates that you see there are fairly large, and a lot of the men there are fairly skinny. So when you have a large prostate in fairly skinny men, it can get difficult because the space is quite tight. So you have to make sure that you have adequate preparation, both with suturing the proximal part of it, as well as the distal part of the dorsal venous complex. And you want to make sure that you're gaining the whole thing. So I'll make sure that I grab everything above the catheter and sew everything underneath that before dividing it. The other thing that I'll do too is isolate or separate the neurovascular bundle early from the prostate in order to help maintain both continence and erectile dysfunction. So this is kind of what it looks like after you dismember it with the urethra here. This is kind of the finished product. And then after I dismember it, I will place these sutures here so that I can make sure I get good, adequate bites of the urethral mucosa, and that'll really help with the anastomosis later. As I go through, I will have one suture that's on a needle still, so that if there's any bleeding, I can quickly reapproximate it and gain control of that bleeding, such that this is kind of the end result that I'm hoping for here. This is the DVC all sutured up. These are the neurovascular bundles that I can see behind, with the urethra kind of still waiting to be dismembered there. Once we dismember the urethra, I'll just go through the anterior part and then put in my first initial sutures so that it can, I can make sure that I get good, adequate bites of the mucosa. And then the rest of the part is actually a little bit easier, because then as I'm gaining traction and I pull back on the prostate, I'll be able to separate the different attachments here, and again, bring up the prostate and separate these from the pedicles. The other portion too is really isolating this prostate from the bladder neck. And that part you can take with electrocautery or suturing. That part is actually fairly straightforward to do. But sometimes you'll be left with a very big bladder neck, which will need some reapproximation, usually with interrupted sutures as well. This is the part that gets very, very difficult. I spend most of my time concerned and worried about the anastomosis because this is where you will get a significant amount of your urinary leakage. And you can have the repair also fail if this is not done correctly. Ideally, I would like 6 sutures, again, kind of in this consideration, configuration, going from the bladder neck part here to the urethra down below. And once these sutures are in place, you really want to be able to make sure that each knot and each tie that you throw is secured. And then I'll have the Foley catheter on a slight amount of tension to ensure that all the urine is going through correctly. Any initial questions just about the surgical approach? That's a very quick overview. Usually I leave, there's a video that I show, but in light of time, I just wanted to just cut it there if that's okay.
I will go first. Yeah, that's okay for the procedure of radical prostatectomy. Unfortunately, I can say that most of the patients that come to us, my colleagues will confirm, most of the patients that come to us already have an advanced disease, which is no longer localized to the prostate only. So undergoing this kind of procedure is really rare. It's rare to perform these procedures here. Yes.
Yeah, and so that's what the next part of this talk is on, is just how to manage and handle advanced prostate cancer. This is also where things are a little bit difficult because we know that the price of most of the recommended medications these days for advanced prostate cancer are quite expensive. And so these things are difficult in areas that may not have the resources in order to share that. Can you tell me a little bit about what do you primarily do bilateral orchiectomies for your castration, or how do you, or do you have access to like leuprolide or to any of the other agonists or antagonists? What is the primary treatment that all of you usually do in order to treat metastatic prostate cancer?
Definitely, it's always bilateral orchiectomy. We rarely start with drugs, Zoladex or Casodex. They are very expensive here. So most of the time we go, we definitely do bilateral orchiectomy for castration.
And then when they become castrate resistant, what is usually your next step then if you don't have any of those medications?
Mm-hmm. We have no other option.
Do you have docetaxel available?
Yes, it can be. It's available, but very expensive. So people who can afford it are very few. And most of the time, those people who can afford it have already gotten treatment elsewhere. Maybe they have gotten radiotherapy, or they go abroad for further treatment. People who are staying here will rarely be able to afford docetaxel.
This is tricky. So let me just briefly go over some of the other medications and the newer updates. But to be honest, I would be very curious, and I would want to stay in contact with all of you to see what we could help you with in terms of either improving some of the access or building a strategy to better care for your patients. Let me go through this part first. It only takes about 5 minutes, and then if it's okay with you, I really appreciate a communication, or at least talking about this. Okay, so the big things to know about the metastatic space. is that we know biologically there's a very big difference in terms of how tumors respond if they are castrate sensitive or hormone sensitive versus castration resistant. And so what we're noticing early on is that in this state where they are metastatic but sensitive to castration, that earlier chemotherapy, earlier treatment with stronger anti-androgens is highly effective. And so these are all the different studies that I'll go through that show this, but these are mostly, again, some of these very expensive medications. I mean, these medications are in fact so expensive that a lot of just Americans, even with good health insurance and good coverage, are not able to afford it. This is something that we are experiencing a very big problem with as well. Because it's unfortunate that basically, no matter where you are, what country you're in, if you have money, you get better care, unfortunately. And that's something that I've been trying to actively work against, or at least show that that is a big problem. But one thing that, if it's available, docetaxel, especially if you are healthy and there's a lot of disease. So for example, if you have, so this major study basically separated people who are not castrate resistant, are castrate sensitive, but they looked at how much metastasis did they have. Was it more than 4 spots on the spine, or did it include visceral metastasis, like to the liver or something? That was considered high volume versus low volume, which is 1 or 2 spots. And what they found was that for high volume disease, you can see it's pretty clear here. The green is hormone therapy with docetaxel. The bottom one is hormone therapy alone. You had almost a 40% increase in the survival if you gave these patients docetaxel. You compare that to low volume disease, there is very minimal difference between the two. And so basically one of the recommendations we give, if it's available, giving chemotherapy early on for high volume disease for healthy people is actually very, very effective. So that's another, sorry, this is the other one. The other one is abiraterone and enzalutamide. Again, those are two of the ones that are the kind of next level or next generation anti-androgens. Abiraterone stopping the production of testosterone. The enzalutamide is a strong non-reversible inhibitor of the androgen receptor. So both of these do show that, again, in this space, you have about a 30 to 40% survival if you started earlier in the space. But again, these pills are fairly expensive. You have to take 8 of them a day. And you have to take it also with a steroid because it overall stops any of your cortisol production as well. The other thing, again, in the castrate resistant setting, then we're looking at some type of medication. The one thing that can be offered is radiation. Do you have like radiotherapy centers or like a cyclotron or anything of those available for your patients? Okay. Because most of these will either be some type of again, having Casodex and, Leuprolide or some of the other ones is effective, but we know that it's really only a matter of time before patients become resistant to those, especially when you're trying to deal with these with surgical kind of castration first. Yeah, this poses a very, very interesting question. Let me just go through the rest of this real quick and then see if there's anything else to hit on before we really get to the next steps for this. Yeah, again, chemotherapy, radium, which is a radionuclide, again, is very effective with bony mets, especially if they have pain and they're symptomatic. But again, you would need to have access to some of the these nucleides to be able to help with this. The one thing I'll say too, there is one of the other. I'm sorry. Do you have cabazitaxel? Sometimes it's a little bit older than docetaxel. Sometimes it's more easier to get. Do you have access to cabazitaxel as well, or is just any chemotherapy is overly expensive?
So far, only docetaxel is available. I've never heard of cabazitaxel. Yes.
Okay, so yeah, this is again for further studies, but why don't we, if it's okay with you, do you have specific questions or cases that you would like me to go over? Because I'm curious about how I can, you know, how we can work together and what are some strategies that we might be able to see to improve the health of your patients that you are seeing right now. So for example, we are undergoing a study right now because I think there is good data, retrospective data, so it's a little bit biased, but I do think that for younger patients who have metastatic disease, doing a prostatectomy for them, even if it's metastatic, does provide benefit. In the States, it's usually done in the setting of adjuvant. So usually it would be done in the setting of prostatectomy followed by hormone therapy with radiation. So it's usually done in a combination setting. But for your patients that are metastatic and young enough, doing a prostatectomy for them may be something that could be considered or could be reasonable to consider if there are no other options for them. Has anybody, is that being done historically, or is that something that you all have considered? I know that for us, we will do it sometimes if their prostates are so big and obstructing that they just are not able to urinate or void. And so we'll do it more for a symptomatic voiding standpoint as opposed to a disease control standpoint. What are your thoughts on that?
I don't know if Dr. Shavani or Dr. Revelien would like to say something about that.
Okay, hello everybody, and please apologize me for being late on the line. And I ask you to apologize me for my bad English because I don't know to speak very well English. But I want to tell you my point of view about the prostate cancer. In our country, we receive the patient which are on the high, I don't know how to call it, which they are on the high level of the cancer. It means we receive the patient if they become symptomatic. And it's very difficult to have a patient which who come for screening for PESA, and they found him if he's eligible for prostatectomy. All the patients we receive here in our country, we receive them on the start of metastatic prostate cancer. And it's very difficult to do something here because all things we can do here is to do the chemotherapy, the hormone therapy. And now we have recently we have the chemotherapy by docetaxel, and we have other things to do here because the people comes later for screening for prostate cancer. I don't know, Siva, I don't know if you have catch something because I speak very bad English.
No, listen, I only speak English and Korean. My French is even worse, and my Kirundi is also, I don't know Kirundi, so it's okay. That's okay. So you know more languages than me. Okay.
I know.
So this is why it's okay. Dealing with widespread prostate cancer is very difficult. And when it's metastatic, this is the problem that we run into, is that when it's metastatic, it becomes so aggressive. It totally changes. Because the only treatment we have surgically is really testicle removal, and we are very reliant on medications. But the best medications we have right now are very expensive. So the question is, what can we give and what can we do that is easier to give and cheaper to give? And to be honest, I don't have a good answer. Yeah.
I was going to ask, what's your opinion on ketoconazole and plus any other steroid? What's your
Very
thought?
good question.
Yeah.
So ketoconazole is effective, extremely toxic, and you have to keep a very close eye on their electrolytes, and also they have to stay on prednisone. So that's why it's one of those that, to be honest, I don't have any personal experience with ketoconazole anymore, because we just never use it because of how toxic it is. That being said, ketoconazole is very available. Do you have, can you get prednisone as well? Is that something a little bit more easier to get? So
it's cheaper and easier to get. Yeah.
The problem that you'll run into is that the resistance mechanisms to ketoconazole usually happen pretty quickly. I don't know if you've seen this in your practices, but usually we say, hey, this can happen sometime. People will become resistant to these medications. Hard to know how fast, but usually it can take about 12 to 18 months after therapy, if they last that long. So you might see initially very good response, but sometimes you have to be careful with how long it is, and especially when it's so toxic. So that is very difficult. But ketoconazole, that's a very good point. Let me write down my notes for this. Okay, very good question though. Here's a question for you.
Sorry.
Yes, sir, please. Dr. Shabani, go ahead.
Yeah, it's just I'm sorry for my poor English. And so my opinion about prostate cancer, especially in our country, Burundi, as say my colleague, Mr. Reverien, we have many problems. Many problems. One for diagnostic for prostate cancer, to have some to do some exams just to see if we have metastatic other localization, and also for the treatment we have we're poor in our country, and so for diagnosis many patients come very late, very late, and also it's not easy to have the diagnosis of prostate cancer early. So just the question, as I have, or my opinion, my suggestion, there is available to make for all patients, donc black patients who comes in consultation to make a prostatic biopsy regularly. Donc, everybody who comes in consultation with PSA is a high 4 or 3 to make immediately the prostatic biopsy. I think there is a more strategy to have to detect the prostate cancer early, I think. The second problem we have just to make the some where we have it. Also for the treatment, as says Ms. Galina and Mr. Reverien, in our country, only we can do the castration, surgical castration, because the Zoladex as acetazoledronic is
Oh no, did we lose him? Dr. Shabani, are you still there? Okay, no, unfortunately, I think we lost Dr. Shabani. Oh, there we go. Is he coming back? So one thing I wanted to ask all of you while we're waiting for Dr. Shabani, when you castrate or if you do Zoladex, do you follow the testosterone levels or the blood counts at all? Okay. And then how quickly does that return back to you? How quickly does that come back, or how long does it last for on average from your experience? The microphone?
Yeah, sometimes it takes time. It takes time because these kind of lab tests have to be paid by the patients. And, you know, these kind of diseases mostly happen to people who have already retired, whose economy are very, very like low. So sometimes they would take time to come back to us for a control of the PSA or the testosterone and the other lab tests that we want to roll out. Yeah, on average, patients will come back to me after between three to 6 months, between that, and that's when I get to do a PSA and testosterone check. Yeah.
Yep. Dr. Shabani, I'm sorry, your connection is a little bit not working. So I think we lost some of your questions before. Are you still, can you still hear us? Okay. I think I don't know if you can text Dr. Shabani, but you know, his connection is just a little bit not working. Any other questions that I could, Dr. Reverien or Galina or Dr. Shabani? Okay. Sorry, your connection is a little bit off. So we had trouble with your question before. Okay, no problem. You know, I hope if it's okay with you, one of the things that I love doing is education, and trying to build more teamwork, you know, more collaboration together. I hope in the future, if it's okay with you, I do wish to visit Burundi, you know, to visit your hospital and visit your work, and to see if there's a way that we can really build a team together to help improve, you know, your care in your hospital, because that's something that, you know, I hope that we can build together. Do you have any questions, more questions for me that I could answer?
I would like to take you back to ketoconazole. Yeah, you said normally it has real resistance. Maybe the patient will benefit from it for about 18 months. But do you keep the patient on ketoconazole for 18 months? How long do you keep? Yeah. How long? And yes. Mm-hmm.
This is where it gets tricky. So ketoconazole does work, and it tends to work pretty quickly. But the problem with it is that, you know, how quickly things come back afterwards is really tricky. So usually what I do is I would need to make sure we keep a very close eye on their PSA and testosterone level. And then I'll be a little bit more intermittent with it. So when I see that I have good response, both from a PSA count, also from a testosterone count, and usually I'll, you know, make sure we follow their symptoms, make sure that they're looking okay. And then from that point, then I'll say, hey, we have a good response. And usually I want to see more than a 50% decrease in their PSA. So if their PSA blood count was, say, 10 nanograms per deciliter, then I want that to be lower than 5, or as castrate, or as low as I can get. If I can get them to be undetectable, then that's great. But a lot of times you might not be able to get to that point. Most of the time, my experience with ketoconazole has really been only when it's been as a last end, or kind of final, a final choice for patients. So I'll say that my personal experience has been fairly low. But you can do, for example, low doses. That's the 200 milligram one, 3 times a day, and see how that works. That tends to get a little bit better, less side effects, but still maintain the efficacy. But still, you are going to see a lot of fatigue, nausea, diarrhea, GI side effects, things like that. It's, you know, it is difficult. It is very difficult. Are you using the ketoconazole? Are you doing the higher doses, like the 600 to 800?
200 milligram every 3 times a day.
Oh, so you are doing that? Okay.
Yes.
Yeah, so that's something that is for us what we consider the lower dose of the ketoconazole, but that's something that we've had, you know, decent efficacy or effectiveness with, when possible. What I can do too is I can, you know, send over some of our kind of practice guidelines for how we use the ketoconazole. And also some of the effectiveness, and I'll ask some of our more senior members who've used it in the past about some of their advice in using it, if that's okay with you, and then I can email that to you.
Thank you.
Okay, perfect. So is there anything else? Yes, sir, Dr. Riviere.
Yes, just a small question. You talked about association of IDT and docetaxel. And I want to know if we IDT we thought about the agonists and the antagonists or oral IDT, or if you put someone oral agonist, you can associate it with docetaxel, or we do agonists and anti-androgen antagonists, and we had finally the docetaxel.
Yeah, so that docetaxel was actually in combination with ADT. So it's docetaxel on top of the ADT treatment. So you're just adding the docetaxel on it. But I would really save it for people who are younger and healthier, because so the best benefit was really younger guys, less than 65 or 70, good functioning status, walking around, feeling healthy with a lot of metastasis. So those are the people that had the best benefit.
Okay.
Sorry.
Yes, sir.
Yeah. I'm sorry. The posology, the dose of the ADT. What the dose of the ADT?
Oh, well, so which one, for which one are you doing? So for the ketoconazole, the low dose, that 200 milligrams of, every 8 hours or 3 times a day. Which one are you, which medications are you talking about? Like, for example, the Casodex, it would be 50 milligrams a day. Or if you're only using it as the only therapy, it's 150 milligrams every day. But usually we recommend doing the Casodex in combination with some other agonists like Leuprolide or Lupron. I think you were saying you used Zoladex, is that correct?
Goserelin, yes.
Yeah, for some patients.
And then do you have access to anything like Firmagon or anything else, or is it really just like, do you use mostly the Casodex and the Zoladex?
Mm-hmm.
Okay. Okay, any other questions I can answer? So I think probably what I'll do too, I'll make sure that I go and send over a list of some of these other, like our dosing strategy and how we adjust the medications according to their testosterone levels, and at least go over some of these early strategies to see if that might be helpful for you.
Yeah, that would be great. Thank you.
Thank you.
Okay, perfect. Listen, it was very, it was a pleasure to meet all of you. Again, I do hope that you'll let me, visit you in Burundi, because I would love to visit and, learn more about your country. And, hopefully, with the virus going away, hopefully it goes away soon. We'll be able to see each other soon. That's what I hope.
Yeah, hopefully, yes. Will we have some time to go over some cases?
Sure. If you want to do that, I only have maybe 5 minutes left before I have to run back to the operating room, but I think that's okay.
I don't know, Dr. Riverien, if you have any case?
Yes, I have one case. It's a patient which about 65 years. I saw him in 2017. It's a patient who have a low urinary tract symptoms, and which evaluated in accurate urinary retention. And in the examination, the digital rectal examination, I found the prostate, which is a very, I don't know how to call it in English, but prostate pierese in French. I don't know how to call it in English. And I asked him to do an ultrasound, which shows the prostate about the weight of the prostate was about 40, 45, and the ultrasound shows us the erythrohydronephrosis, the left erythrohydronephrosis, and more pelvic lymphatic nodes. The PSI was about 32, and we have done something like therapy in order to facilitate to the patient to have the mixtion, and I put him in the left kidney tumor stent, and I have a performance also again the androgen deprivation therapy, and I follow him, but I was not in the country, and meanwhile he go in the French, and the French they do the CT scan and the MRI, which saw the secondary lesion in more space. And I saw him in this December. He come for the cervical and the lumbar spine pains, and it was the PSI and the testosterone was increased. He do a CT scan of spine, which showed the fracture of C2 and the T4, and sorry.
No, go on. And
other secondary lesion of the axis of the spine, on the costal, scapular, pelvis, right trochanter, and the humerus. And they asked me to go in the French again, and they turn in the French, and in the French they do the radiotherapy, and it come back here, and we began with the Dastaxel, the chemotherapy by Dastaxel last week, and I present this case in order to know why. I don't know why, because I don't know why the evolution were very bad in the few time like this, because he was on the private and on the IDT, and the evolution is go I don't know how to call it. The evolution was not very good as I told you, and I want to know if in your practice you have the case like that, because here this is a patient which who is in the high class of the people here, because the other people they come. I told you that the people come here to consult if they have symptoms, and if they have symptoms, it means that they have metastasis somewhere. And if we do IDT by pepectomy, more time we don't see them again, because here in our country the people come at the hospital if they have symptoms. If they have no symptoms, they can't come to tell us the evolution, and that is the question the problem have. And these people, the case which I present to you, I present to you because I see the evolution, I want to know if in your practice, the case like that, which the diversion is very, very quick like that, you see frequently. Thank you. And they apologize me for my bad English, please, again.
No, please don't ever worry. That's okay. So listen, your case that you presented is something we see and very hard to predict. A lot of times we don't know when we put them either, we think that it's going to go normal. We think that they will have response and that they'll be okay. And then all of a sudden their disease starts going. One of the things that we do worry about is you can get, instead of a hormone therapy, remember, is only working for a short amount of time or for a temporary amount of time. Eventually, all the disease will become resistant to it. So it's either that it's resistant to the hormone, or the cells are transformed and they become what we call small cell or neuroendocrine. I don't know if you have that there, but that is actually a very particular type because the neuroendocrine features do not make high PSA levels, but they are very aggressive and they can go like that. So that's why it's always important that we are very careful, we stay vigilant, and we keep watch of these patients quite closely. But I mean, listen, we've had those patients too, and I'll say that it's very, very hard to treat them because these things can change like that. And usually what we would do also is just keep track of their PSA and testosterone levels too as we're going. But it is very difficult. Usually, so kind of what you were saying, like radiation is something we use a lot of in conjunction or together with the hormone therapy. One of the biggest studies has shown that if you give hormone therapy or if you give the ADT and you do local prostate radiation, that is much better than ADT by itself. So we are using radiation a lot more than before.
Sorry.
But did you get that? So unfortunately, I do have to run back to the operating room, but I will be sending you at least the email with some of that information that we have. And this is just introduction. It's only us saying hello. So if you have any questions, or for example, Dr. Reverian, if you have any questions or future patients that come up and you want to ask me, please email me. Use me as a kind of resource or information, and that way we can make sure we keep communicating and keep talking with each other.
No, I have no questions.
Okay.
Maybe next time.
Okay, maybe next time. Okay, so listen, it was a pleasure. Thank you very much. Okay, it was very nice meeting you.
I had another case to talk to you about, but maybe I will just email it to you.
Email it to me. Email it to me, and then I can respond to you.
Okay.
Thank you.
Okay.
Yeah,
Thank you, everybody.
Thank you very much, sir. Thank you.
Thank you very much.
Thanks. Yeah, and thank you to all of you for organizing this. We can definitely host more lectures and perhaps even another one with Dr. Lee.
All right, bye-bye.
Yeah, bye, thanks.
Bye-bye.
Bye.
Bye, thank you.
Bye.